I am Jody Goodkin, and I will be your presenter today for our topic of podiatric surgical procedures, considerations, application, and management. Before we start our topic, I'm just going to take a few minutes and review a little bit about how the course will run. We do have course notes available that will follow along with my PowerPoint presentation, minus the images because of copyright. You can access that course notes packet by going back to our website, cheapcus.com. You'll scroll down to our topic for today and go to the right. There'll be a link to access those course notes. You can either save them electronically, print them out, whatever you prefer. You do want to have them available in some format to follow along during the course and for when we take the course post-test later on today. Our topic for today is podiatric surgical procedures, considerations, application, and management. My name is Jody Goodkin. I have been a physical therapist for over 30 years and involved in physical therapy education for over 25, and I look forward to discussing this topic with you today. What we will explore during our time together for this course is looking at those surgical procedures that are utilized to manage the orthopedic conditions of the distal lower extremity. We'll specifically look at the current literature and trends in surgical management for the tendons, ligaments, as well as the bones of the different foot and ankle joints. The rationale for our course is to enhance our understanding of these different surgical procedures, to look at the biomechanical changes that do occur during surgery, and to utilize that as our foundation for making our clinical decisions in terms of rehab components for our patients with the distal lower extremity surgical procedures. We will take time to look at procedures that are utilized to manage degenerative changes as well as traumatic and non traumatic pathologies of that foot and ankle complex that involve the tendons, ligaments, and the bones. Because this is a surgical discussion course, please know that I am very well aware that we are talking about a whole person. Just the nature of the course lends us to talking more about anatomy versus the person, but know that I am acutely aware of that, as I know you all are. Also, there will be images put up of different surgical procedures at different points during the course. So depending on where you're viewing us from, if you might have eyes that might be uncomfortable with some of those things looking at your screen, I just like to give you a little bit of a heads up on that. Our goals and objectives are aligned to accomplish what we are discussing today. The different procedures that we're discussing are utilized in patients across the lifespan, pediatric adults as well as elderly. You should be considering that you will be seeing patients who have direct trauma pathologies that may require these different surgical procedures. Maybe it's a sport injury, maybe it is a motor vehicle accident or an occupational injury. Also consider that some of the patients that you will be seeing with these conditions have other orthopedic injuries, and now they have had to compensate and substitute with their foot and ankle on their involved or uninvolved side, and now it has developed pathology. Also, those individuals with different neurologic conditions we might see presenting post-surgery for some of these procedures. While we don't cover specific protocols, and as we go through the surgical procedures, you'll enhance your appreciation of why there's no one set protocol, because a lot of these procedures are utilized in combination. I will highlight for each different surgical procedure what we need to be thinking about in terms of progressing the patient, and what we're seeing as some of the trends in when to progress and key things to include in your rehab for those patients. When you do go back into the clinic to apply this information, you will do so in accordance with the federal, state, and professional regulations where you're practicing. And also, no conflict of interest exists for the presenter or the provider of this course. As you look at the PowerPoint presentation slides as well as the course notes that I've provided for today, you will notice that several of these slides on the bottom right have this icon that is a gold icon that says consider this. That's to let you know that those particular slides are going to be helpful when you go to answer those post-test questions. And here we go with our content for today. We are going to take a look at the foot and ankle complex. So we will start with a brief little review of our bony structures here in case it's been a little bit since you have looked at them. As we look at the foot and ankle complex, we have our normal foot biomechanics that are going to be related to our structure of the foot. Just to review the different regions of the foot that we're looking at, we have our hind foot that makes up our talocrural joint. So that's our articulation between our tibia, our fibula, and our talus. That is where the majority of our dorsiplantar and some of our inversion, eversion is coming from. And then we have our subtalar joint here that is going to be between that talus as well as that calcaneus. So that makes up our hind foot. We have our midfoot region next. Those are all of our tarsal bones. We have our navicular that is medial here that we are looking at for that arch height when we talk about pes planus surgeries. And then we also have our cuneiforms and then our cuboid out laterally. And also in our midfoot, we are going to have those metatarsals. Our forefoot then is made up of our phalanges, and our metatarsals also incorporate the joint of the tarsal metatarsal area. And all of these osseous structures are designed so that they are creating a mechanism where we have a stable base that can be made for propulsion to move the body through the gait cycle. When we look at the arthrokinematics, when we actually go to move and complete that progression through our gait cycle, we need to think about that in addition to all of these static structures that we just talked about, we do have a lot of dynamic structures. And those are what will control this bony architecture and allow the individual to progress through the gait cycle, to accept different forces during weight bearing, to perform different functional activities. And all of the ligaments and the tendons in the region, as well as the joint capsules, which there are many between all these articulations, those are going to be our dynamic structures, our dynamic stabilizers in order to work with our muscles for functioning of that foot and ankle. The kinematics, when we think about our patients who are rehabbing from these procedures related to the foot and ankle surgeries, we're thinking about, yes, restoring movement, restoring motion, getting muscle strength back, all of those things, focusing on balance. We need to keep in mind the added piece that there is the ground reaction force that is going to be coming up into this foot. And then also there's the body weight load coming down. In addition to that, we cannot forget those external loads. And I like to say this at the beginning because it's a string that you can kind of take through all of the rehab that we're going to discuss with your patients. When you look at progressions, I think it's very natural for us to think about our progressions in terms of balance, right? We're going to start with sitting just to get the foot and proprioception and some weight bearing through it. Then we'll work to standing, 2 legs, 1 legs, upper extremity support, none, eyes open, eyes closed, different surfaces. That's kind of routine. We also want to think weight coming through those external loads. So another progression in your rehab will be consideration of adding external loads, and can the patient manage all of those different functional balance strategies with varying external loads that challenge them in from different directions with their base of support in addition to surfaces. And that's for just return to function as well as work, because even our elderly patient who is just doing their regular functional activities, at some point that lady may carry a pocketbook or that gentleman may carry a bag of groceries, and that's an external load. So we don't want to forget that. And again, when we look at execution of our patients in these functional tasks post-operatively. We're looking at coordination, we're looking at timing specifically. And our focus today is going to talk about in each surgical procedure, how is the geometry changed? How are the lines of pull changed of different muscles or different structures stabilized so that we can use that to consider where we want to focus in our rehab. Some other general considerations that the surgeon is going to have preoperatively when they have that patient sign that consent to perform surgery. I just think it's interesting to highlight where that information comes from and how they've determined what the different risks are with different surgical procedures. The information is actually generated from large studies and research where the American College of Surgeons, the National Surgical Quality Improvement Program, surveys 35,000 patients, gathers all their health information. We're talking about foot and ankle, so they looked at those that had the foot and ankle procedures, and then they look at all of their preoperative and postoperative data and then the complications that they are likely to develop within those first 30 days. And that is what's monitored. A couple that I want to highlight that if you are seeing patients preoperatively or earlier postoperatively with ambulatory care, that's most of us now. Um, we want to be attentive to the creatinine level. The creatinine levels that they have found, if it is greater than or equal to 1.3, they're finding that that is a risk factor for potential postoperative complications. And then with our albumin levels, if they're finding albumin levels that are less than 38. This comes into play particularly for the foot and ankle, these levels, because they, not to get too much into the physiology, but we're looking at how leaky the different vessels become and how much fluid is released into interstitial spaces, as well as calcium movement and different hormones that are necessary for healing. These play important roles in that to facilitate healing for our patients. So something to keep an eye on there. The different types of anesthesia that are utilized for patients who are undergoing procedures of the foot and ankle. General anesthesia is commonly utilized where the patient is completely under, but also regional or neuraxial type of anesthesia is being utilized more for the foot and ankle region. Really, the research hasn't found that one way is better than the other. We know that patients that undergo general anesthesia, we need to monitor them a little bit more closely post-operatively for that potential respiratory compromise. In both cohorts of patients, we're finding that there are no specific differences in the complications that are seen. However, they are finding with more regional anesthesias that the length of hospital stay is shortened, that the patient satisfaction is greater, that we tend to see less pain medication use. So we might see more increased use of that. And peripheral nerve blocks, we're really seeing an increased use of to help manage that postoperative pain for our patients that is going to be administered pre or perioperatively for the individual to help carry over into that postoperative period to manage some of that pain for them so that hopefully they're going to utilize less pain medications. We'll see hopefully less opioid use, particularly in that first 24-hour period is when they are most beneficial for the patient with the peripheral nerve block. For our patients who receive that, who have these foot and ankle procedures, we need to pay extra attention to monitoring them for compartment syndrome, which we're already doing, that patients are at risk for that swelling and that compression that could lead to significant neurovascular compromise, as well as venothrombus embolism, those clots that can develop. Well, we often rely on the patient verbal feedback to kind of be one of our early cues that this may be, these two conditions may be developing. Unfortunately, with the peripheral nerve block, we're not going to have that to rely on. So we're going to have to use our other assessment skills, visual inspection, palpation, to monitor for those specific conditions. And then also rebound pain. This is a concern with patients who undergo peripheral nerve blocks. And the challenge with rebound pain is that the goal of the nerve block is to have the patient use less pain medication so they are not at a risk for that opioid dependency. And then also it's controlling the pain to get them up and moving earlier to minimize complications and length of stay. We know this, that's nothing new. What rebound pain is, and we're more aware of it now, it's that transient acute increase in postoperative pain following the wearing off of that peripheral nerve block. That's that significant difference in pain from when the nerve block is in effect to when it's not. And that individual has pain, if it's specifically rebound pain, that's actually higher than they would have had if they didn't have that nerve block at all. And here's what we understand at the current moment related to the physiology of this. So the patient undergoes a surgical procedure. We know there is certain trauma to the tissues, so those nociceptors are going to fire. We know that's happening. Well, the peripheral nerve block is dampening that pain. It's not being perceived by the patient. And we know this from other pain pathways that during that time period, great, the patient is not perceiving the pain, but those receptors are still firing. This pain memory is developing. So we have that central sensitization to the pain, and it is building. Peripheral nerve block is wearing off. And when they reach that point, if the peripheral nerve block is gone, now when it subsides, this is when we're having that increased amplified pain. The extra concern is that this often happens to patients about 12 to 24 hours after that nerve block is administered. And with ambulatory surgery for the foot and ankle, they're home now. It's probably the middle of the night. They're getting up and moving, and they thought they were doing pretty good managing all their precautions. And now they have this significant increase in pain. It stresses the cardiorespiratory system. It increases ER visits for these individuals. It creates a lot of distress and stress to them. Many times patients then will start questioning the surgical procedure. They're hesitant to use that extremity. So what we need to do is educate our patients that this could happen and how to avoid it. It is very important that they take the anticipatory pain medications. So they're taking the medications as prescribed by the physician while that peripheral nerve block is slowly wearing off, so they'll come to an even out point. So they will not have that increased pain. Otherwise, unfortunately, we see the opposite happening where there's greater use of those opioid medications. And some of you, I can feel the head nods with this. Educating certain patients on this, because it's abstract, we need to get them to buy into it and believe it and know that it happens, because we don't want them to end up in that rebound pain situation. Generally speaking, when we look at pain management for patients, at lower extremity elevation is really an important component of it for foot and ankle patients. They're not utilizing their muscle pump. So yes, they have risk of clots. We know that we need the circulation to that distal extremity for healing to minimize risk of infection. So lower extremity elevation is important. Some surgeons say that they should be elevating that lower extremity for 50 minutes out of every hour during those initial stages. And then there are also recommendations coming out when we look at patients not just getting that number rating for the pain, but attaching some function and additional meaning to it. The North American Foot and Ankle Surgeon Consensus says that when we're documenting pain for patients, we should document how it is contributing to their ability to participate in therapy. Is it inhibiting their ability to participate in therapy, or is it manageable? And we want to look at, particularly because our foot and ankle patients, they went into surgery because they were having challenges weight bearing, walking, doing their functional activities. They've probably been compensating for a long time. Now they need to relearn to trust that foot and utilize it for all of their activities. That the pain catastrophizing scale is something that can be utilized to try and kind of quantify where the patient is at in terms of their pain and how impactful it is for them. What they're finding is a score on that of greater than 30 is something that may warrant additional referral to look at pain management and psychologically how this patient is processing. And then the hospital anxiety and depression scale, a score greater than 15 on that scale means that that patient may benefit from additional resources and services to help them kind of make that connection between their thoughts, behaviors, and feelings about pain and mobility, and then actually now being able to progress and rehab. Because the real focus here is early mobilization. We know getting patients up and moving despite the pain they're having in a controlled way, we know is beneficial for that healing process. If the patient's pain and inability to participate goes beyond that 2 week time period, in addition with your subjective findings, that's maybe where you were starting to think about a neuropathy, chronic regional pain syndrome, something else developing that we want to catch early for that patient. Some things that are being utilized during surgical procedures to enhance healing postoperatively, tranexamic acid is utilized now with the foot and ankle procedures. It's administered perioperatively for the patient, and the focus is for it to prevent blood loss. When we think about the foot and ankle, we're not thinking about massive volumes of blood loss where we have as significant a concern of anemia. While that may be a concern with some patients, sorry, what we're thinking more is that, for example, the calcaneus, that is a very blood rich bone. So when the individual's having procedures, either where they have to drill into it, maybe to stabilize a tendon and move the footprint of the Achilles tendon, or if they had a fracture of that calcaneus that's being stabilized, or other bones in the foot and ankle, the concern is that bleeding out into that interstitial space or that interarticular space, that individual is at risk of a hemarthrosis or hematomas forming. And then that encroaches in all of these small joints that we have here, decreases their mobility and functioning, and can compromise rehab. And then fibrosis is at greater risk of developing postoperatively, which then can change the mechanics of that foot and really impact rehab and ultimately functioning for that patient. So what they're doing with this tranexamic acid is it's promoting clot stabilization. It's going to affect the plasmin. And also, it's going to limit the pro inflammatory effects. It's going to kind of tone down some of those inflammatory mediators. And it's a balance between still allowing healing to occur, but not risking that fibrosis, hemarthrosis from occurring for the patient. So, we're starting to see more use of this in foot and ankle procedures. Nitinol hardware, if you just take a look at the top of this slide, look at that capital N, lowercase I, capital T, lowercase I. Some of you may be having a little bit of a flashback to that lovely periodic table of elements that we all had to memorize throughout our careers. And you would be right. That's where this name is coming from. Nitinol hardware being utilized in many different surgical procedures, but advancing now in the foot and ankle, stands for Nickel Titanium Naval Ordnance Laboratory. This is a material that they've developed that is it's resilient and it returns to its resting state. So it's dynamic but stable at the same time. And it actually came back in the 1960s when they were developing through the Navy new nose heads for the missiles. And then somehow someone figured out that, wow, these traits would really be beneficial in the human body, and it's been adapted. It's been utilized for a long time in vascular and dental procedures. What we're looking at here in the bottom images is an example of a stent that's being utilized. And we can see it's like a mesh fabric that can expand and contract down. So imagine that this is utilized to stabilize a joint. For example, we're looking at this syndesmosis, where maybe that ligament has been disrupted and we need it to be stable, but we do still need some movement to occur between these joint surfaces. If they can utilize this alloy that will always shrink back down to its space, to its original size, but it'll dynamically give along with the body heat, it's really beneficial. What they're finding is that as there's bony reabsorption around these different types of nitinol hardware that are utilized even to stabilize fractures, that it will still continue to give the compression, and then it can accept the strain loads and be dynamic at the same point in time. So we're seeing for arthrodesis, fracture, ligament stabilization, that this is an advancement that helps. And we're also seeing then that it allows earlier weight bearing because it is going to be stable at whatever state or size or distance it's placed into, and then it'll more likely replicate what that natural structure would have done, which is why we're going to see changes in weight bearing status. So if you're starting to see different weight bearing status, or you see one patient that's allowed to advance earlier than another, you might want to get into that surgical report or get with your physicians to know what type of hardware they're utilizing. It might be this shift, which will be positive for our patients. As we look at different types of grafting that may be utilized in our different procedures, now we're going to talk about our different tendons that may need to be augmented or replaced in the foot and ankle region. We're always going to assess that donor site to see what compromise may exist. And the donor site is going to be taken from somewhere where there's usually a redundancy, or it's in an area that will not compromise the patient, not giving up one thing for another. And they've done some research looking at, well, how do those donor sites actually respond? Commonly, the peroneus longus and brevis are utilized in order to move in the foot and ankle. Often, surgeons are going to pick an area where, if they're already in there doing surgery in the foot and ankle, then they can slide that peroneus brevis tendon over to help reinforce maybe that Achilles tendon. That might be done rather than coming up to a more proximal donor site. And then we just need to know in rehab what that donor site was so that we can make sure we strengthen up that area also. The flexor hallucis longus is another common donor site that is utilized. We want to make sure that we are assessing the hallux flexion for that patient. It is important that that toe remains stabilized on the ground. So if that was the donor site that was utilized, part of your rehab is going to incorporate looking at that patient when you're doing those weight bearing and balance exercises as you progress. Make sure that that toe isn't lifting. Make sure that they can keep that toe down during the push off phase of gait. You may need to do a little extra specific strengthening for that joint, even if your focus is more proximal, because it does all come together for that patient. The semitendinosus and gracilis are the most common free tendon donor sites, meaning where it's taken out more proximally and then relocated down to that foot and ankle region. What they're finding in the research is when they look at how strength deficits occur in patients from those donor sites, yes, it's going to heal in that region and not significantly affect strength. What you want to do is look at not just one break test for your muscle testing. So if you're testing, knee flexion, you're not just going to take it mid-range, check it and say, oh, good, we're all set. What they actually found is that for these particular muscles, the knee flexion strength deficits is going to occur most commonly at about 70 and 90 degrees of knee flexion. So you might want to do multiple angle muscle testing in comparison to the non-donor side to see where you need to enhance your strengthening. And if we think about our hamstrings and how those hamstrings need to have strength to decelerate through that gait cycle, we're looking at different ranges, right? We're looking at more the end ranges. Well, we don't want to forget those inner ranges of strength that are needed for different types of activities. So I like to mention that you just want to do multiple angle muscle testing, and you may need to isolate your strengthening. Maybe they need some type of isometrics at different ranges, or if you're using dynamic stabilization standing exercises, have the knee in different degrees of knee flexion while you're working on that for them to build strength. Bone autographs are utilized in order to help our patients heal from different arthrodesis, or if they are adding a little extra packing to an ORIF location. Iliac crest historically has been where grafts are taken from, but again, we're seeing more of a trend where surgeons are trying to stay in the local area for their donor sites. So they might stay ipsilateral, but for purposes of my image, I just made it a little easier to see here. They may take from the tibial tuberosity some bony matrix to implant into that foot and ankle. They'll take from that lateral malleolus of the tibia. And then another common site might be from that. I'm sorry, I got to erase there. I meant to say medial malleolus. There we go. Medial malleolus of the tibia, and then also laterally from that calcaneus, which has a good bone stock in that area. We want to monitor our patients, again, knowing where that donor site is from. For example, the reason this would be important is ability to wear shoes is an important goal for our patients following foot and ankle surgery, and different types of shoes for different activities or different jobs. Well, if they're unable to fit in that shoe, is it pain at the donor site? Is it discomfort from the surgical procedure that we would expect? If they are having swelling, again, donor site versus normal surgical healing. We need to make sure that we distinguish things to be monitoring that donor site for possible infection or complications of that donor site. So we need to make distinctions as we're assessing our patients visually and with the subjective information that they are supplying us. In addition to checking for sensory deficits that may occur if there was a nerve that was traumatized during the donor site acceptance versus the surgical procedure. The first surgery that we are going to discuss now, that we've looked at some things that are in common through many of the different procedures, is going to be our hallux valgus procedure. Hallux valgus, we know, is that bunion deformity, as it is commonly referred to as. This is going to be, we know that this lump that we're seeing here in this bottom left image, patients often think it's an overgrowth of bone, which we know is not the case. It is actually, we're going to have that translation of the phalanges medially, and then that is that head of the metatarsal that is sticking out. So it's a malalignment that has developed from what is always the question. Is the footwear the etiology or the exacerbator? I wish I could do a show of hands here. It'd be interesting because honestly, over my career, which has been a minute, the thoughts on many of the things that we're discussing have changed. We know now that it's not those stilettos, those high heels, pointy toed work shoes or flats that have caused the hallux valgus. There does seem to be a little bit of a genetic predisposition. For the most part, they're really not sure why it develops, but they are finding that it will exacerbate the progression of it for many patients. So we do want to think about footwear post-operatively, avoiding those pointy-toed, narrow toe box shoes for these patients because we do not want it to reoccur for them. When we look at this procedure and how the surgeon determines if the patient is a surgical candidate or not, they're going to look at the several different angles. So first we're going to look at the angle of the hallux valgus. So this is going to look at drawing a line, we'll go on our first image here, through that metatarsal for that patient, and then they're going to draw a line through the phalange, and they're going to look at that angle here. If it is greater, than 20 degrees, getting up closer to 40 degrees, that moderate to severe range, those are usually looking at our surgical candidates. Another angle that will be examined will be the intermetatarsal angle. So under moderate here, we'll take a look at this. They're going to look at an angle between the first metatarsal and the second metatarsal and take a look at how wide that angle is. And once we're getting over 11, closer to 16 and above, we're looking at those moderate to severe cases. And those are our patients that are looking more at being surgical candidates. These patients may then start presenting like we see in the image in the left with those overlapping with the second toes. If we have a foot that has an apropulsive gait, we know that we need 65 degrees of metatarsal phalangeal extension in order to progress through that gait cycle. And when we have this hallux valgus, that is not happening for these patients. So some actually end up with a gait where they cannot propel their body weight through that cycle. They may not be able to wear shoes. They may start to get some different ulcerations in there, have severe pain. So they're looking at surgical procedures then to restore that anatomy of the foot and function for that individual. There are many different procedures that can be utilized from conservatively from the different references that you look at. There's somewhere between 100 and 130, if you can believe it, different procedures to manage hallux valgus. This is why everything can be done minimally invasive, percutaneous, open procedure. So you have that, and then you have all these different procedures that you can combine different ways. Are you, the surgeon, going to address the metatarsal? Are they going to address the phalange joint? What are they going to address? So there's a mix there. What we're going to discuss are the procedures that tend to be the most common ones. And the first one that we will take a look at is the chevron procedure. The chevron procedure is going to look at that metatarsal head. And what's done is they're going to create a little wedge in this left image here in that metatarsal head, and they're going to take it and just literally shift it over to where it should be located. They're going to shift it out laterally, then they're going to shave off that extra little bony part. They will screw that in place to hold and realign that toe for the individual in that chevron procedure. In the akin procedure, this may be done in conjunction with the chevron or the scarf that we'll talk about next. This is looking more at the phalange. So in the akin procedure, they're going to look at this phalange and do the same thing. They're going to wedge that out. So they're going to take it, they're going to create a wedge, and then they're just going to slide over that phalange to where it should be and then screw to hold it in place. The scarf procedure works a little bit differently. The scarf procedure, it's more of a top bottom procedure, and in the center image here they're going to make a Z kind of top to bottom and create two wedges, and then they're going to slide the top and the bottom. So slide the metatarsal head and the phalange over on the bottom and then secure that down and in place. It's more of a Z cut that is going to be utilized. And then they can utilize different combinations of these procedures. When we look at working with these patients post-operatively, we are going to pay attention to the pain level, obviously, that the individual is having. We do want to be considerate to the shoe that they're wearing initially post-operatively. They're going to have some type of shoe that they will be utilizing that is going to take the weight bearing off of the forefoot, because we do want healing to occur. And in the far right here, we can see this patient preoperatively. I'll enhance the angle, and then postoperatively, following rehab, the alignment that was achieved. So early on, it's important to have them in that shoe or that boot where they're mostly heel weight bearing and they're not progressing over that toe. And then as they're progressing, they're going to start with something that has more of a solid base to it, moving towards something that then will allow progression, because we do want to get that going towards that 65 degrees of metatarsal phalangeal extension back in place for that patient. What we have to make sure is that they're able to control this toe now. So we're going to look at hallux purchase. And the way this works is, let me get my paper here. You're going to have the patient sitting or standing at whatever point you are in your rehab. If when they are allowed to weight bear through that foot, you're going to put a piece of paper under there and try to pull it out. So you're asking them to hold that great toe down and in place as you're trying to pull that paper out to see if they're able to hold that. And then you're going to do the same thing with that paper under the digits. And this is checking to see that strength to make sure that they do have the ability to control that toe and keep that great toe down and those other toes down and in alignment with the foot. So that would, if they're weak there, then you're going to know that you need to do some greater strengthening for that metatarsophalangeal flexion for that patient. Typically, we're going to start going with the patient non-weight bearing passive range of motion, then sitting active range of motion. Know that it's just lifting the toe up and down, in and out, splaying the toes, your typical things you would think of, but how far you have someone reach to have them get comfortable weight bearing on that foot again is going to change the amount of movement they have. Are you, when they're sitting, you're progressing to the point where you're going to let them lift their heel up as they're reaching for something as they progress more, because that's a way to encourage them to get that proprioceptive back, start to rely and trust that foot again as we progress more into our seated weight bearing activities. And then when we look at, further out, like 8 weeks, where we're doing more of our balance for that particular patient, and we're holding off later into the rehab for those different high impact activities for the patient. What we want to watch is if too early on weight bearing occurs, there can be what's called troughing, and that's where particularly with the scarf procedure, where because everything's been split and it's healing, that if there's too much weight bearing, it can kind of sink down the superior part of the bone into the inferior part. And what you'll start to see is that first ray starting to lift and that inability to hold it down. And that's where that purchase check will come in as important to let you know that you might be starting to see failure of that procedure. The next condition we are going to discuss are the procedures that are utilized to manage plantar fasciitis. This condition was previously, with a itis in the name, considered to be an inflammatory condition, which we know it no longer is. Its name more appropriately would be plantar fasciopathy or something of that nature, is more accurate. What occurs in this condition, we know it's that classic pain that the patient has when they first wake up in the morning and their foot hits the ground and they weight bear on there. They have that pain in the plantar surface of their foot, often localized into that heel region or amplified in that heel region. What happens with this condition over time, the reason it develops, it's an malalignment of the forces in the foot because of changes to the arch and the alignment, and then stress is placed on that plantar fascia. So if we look at the image on our far left here, we're going to see changes occurring into this plantar fascia where there have been too many vertical loads placed on it that has traumatized that tissue, created different micro damage to it over a prolonged period of time, and now it cannot function to create that rigid lever to progress over for gait. On imaging, we're going to see these radiographic changes here as there's alterations actually in the physiologic construct of those tissues. Some patients were able to get it to heal. About 90% of patients with conservative management, activity modification, weight loss, maybe an orthotic, were able to, in 3 to 6 months, utilize conservative management and rehab them. Some patients past that 6 month time period, they need minimally invasive procedures. Historically, corticosteroids were utilized. Those are no longer recommended to manage plantar fasciitis. While it may give the patient some short term immediate relief, they continue to engage in the activities that are traumatizing and damaging those tissues, even though they may not be feeling the pain from it. So that's actually over time placing them at a greater risk of rupture of that plantar fascia. So that's why those are not recommended anymore. Platelet-rich plasma, extracorporeal shock therapy, those are starting to emerge as more of the conservative measures. The patients we're focusing on today are those where this has all been exhausted and now they still have severe pain that is limiting their function. Different studies have checked with surgeons and surveyed them on whether or not they actually use surgery to manage plantar fasciitis. One particular one that I read looked at fellowship trained surgeons, and they said that, 10 to 12 months out would be the time frame that they would start considering surgery for the patient if all conservative measures have failed. But the study also found that only 55% of the surgeons actually went on to do surgery for those patients. So it may not be very common that you're seeing these patients post-operatively. It might be done maybe more in conjunction with other procedures if they're already in there managing the foot, or in those patients where they are severely functionally compromised. The surgical procedures, if you want a visual or something maybe more familiar to liken it to, it would be to look at procedures that are done to manage carpal tunnel to do a release in that area. What's done in the plantar fasciotomy is a long blade here in the top image. It's like a stick with a hook sticking up on the end here. That is arthroscopically going to be inserted. And then that is going to scratch across that plantar fascia to create little uh, rips or tears that are specifically designed to start stimulating the healing process that the body did not do on its own. Remember, it's not inflammation there, it's physiologically the tissue has changed in what it's made of and is no longer functional. So the idea is that stimulating that healing process will hopefully then, with controlled forces, allow healing to occur. So it's that hook and blade that's utilized in the images here on the left. We see the fascia that is thick and intact there. And then we see here, generally what the surgeon does is they scrape in different areas of that plantar fascia, and they're creating that opening in the plantar fascia, and they usually go down to the next level of the muscles to be visible. About 30 to 55% of the fibers, depending on the release that is done. Maximum release would not be over 50% of the fibers. And the goal is to just allow it to restore alignment of that foot. And usually we see early weight bearing with these patients. If they're doing an open procedure and they're coming in here, we're looking at the medial foot in this area, and they're coming in and they're creating those little slices in that plantar fascia. That can be done as more of an open procedure. And then those patients, it's going to be a little further out before they're going to be starting them with weight bearing. As we look at rehab for the patient, we need to consider that a lot of times concurrent procedures are done because they're not 100% sure what causes plantar fasciitis. And I don't know why in this particular lecture I find myself saying this a lot, and in many of the surgical things over my 30 plus years in the field. Um, the thought was that the plantar fascia used to get so tight that it would pull away and create that bone spur. Well, now we know that's not the case. The thought is that this little bone spur or heel spur that's occurring here may have existed already. And then that potentially starts the irritation to the plantar fascia, causing the problems. The bigger school of thought right now is they don't know. They found some patients that have these massive spurs, and when they're in there for other things, they find them no problems with plantar fasciitis. Other patients don't have one, and they're in there for surgery to have repair of it. So what came first with the heel spur, they don't know. So oftentimes the surgeon will go in and they're going to resect it out just in case it's contributing to the problem. Also, what they found is Baxter's nerve plays a role. Baxter's nerve, it is a branch that is coming off of the lateral plantar nerve. So we're coming here and it crosses over this way. I should probably pick a different color here. Pick a different color. Coming over this way. So lateral plantar nerve is coming out. It's a little branch that comes over, and they found that this particularly innervates on the long plantar ligament, the calcaneal periosteum. And as there's tightening down and fibrosis in that plantar surface for the patient and of that plantar fascia, it may be compressing on that nerve also. And that's part of that specific isolated heel plane that the patient is experiencing. So they'll go in and they'll clean that out also, debride it out, make sure that nerve is free, to decompress it in case it's contributing. So a lot of times patients that go in for plantar fascia surgery actually are having 3 different procedures done in that area. So when we look at rehabbing these patients, I want to highlight sticking with that Baxter's nerve first. And this is actually good to look at for your patients that are non-surgical also with plantar fasciitis. That Baxter's nerve also provides the motor innervation to the abductor digiti minimi. So you do want to muscle test that out. And it may seem insignificant, but we know that all the muscles in the foot play a role in balance. So it is important to check that in our patients, particularly post-operatively. If there was compression on that nerve, they might have long-term atrophy, and we need to strengthen it up. If the nerve was addressed during the surgical procedure, if they have weakness there, we need to see if it's transient or not to see if that nerve was potentially traumatized. Something else we need to monitor patients for as we are rehabbing them from the plantar fasciotomy is looking at lateral column pain. So the thought is that as the plantar fascia is released, we're going to restore the architecture of the foot, restore that windlass mechanism. That's what creates that tension and gives that lever to progress over for weight bearing. If there is too much of a release of that plantar fascia, well, what happens then is the plantar fascia is going to allow too much of a drop in that navicular and malalignment of that foot. And that is going to shift the weight more to that lateral column of the foot as the person's weight bearing. So again, if the patient is complaining of pain, we need to be specific. Well, where is the pain? Is it from the spur? Is it from the surgical incision healing? Or are they starting to have more of a lateral column pain? That would start to develop kind of from the second metatarsal over. 3 to 9 months post-operatively, when they're really weight bearing and functioning and utilizing that foot, you might see it combined with a little bit more of a pes planus foot position, and that would mean that there may have been too much of a release, and now they're starting to develop a secondary pathology. So you're going to look for these two things in potential combination. A typical rehab for a patient that undergoes a plantar fasciotomy, they're going to start out in that non-weight bearing with the boot and then progress to that full weight bearing. We will do a lot of strengthening exercises, all the typical ones that you would think of, isometrics and concentric eccentric for the foot, the ankle, the toes, all those different structures of the foot. The one that you may or may not be aware of is the doming exercises. So we want to do doming exercises. They're referred to many different ways. Some people call them the short foot exercise. You may have your own fun way of explaining it. The idea is, if this is your foot, and if you've never tried these, I encourage you to try them because proprioceptively it takes a lot. The idea is that when you have the foot, that it's using only the intrinsic muscles of the foot. So this is my foot flat. The idea is the patient is going to dome the foot, literally create kind of that little cave there. They are not creating it by flexing the toes. They are not creating it by supinating the foot. They are literally pulling up that medial longitudinal arch, and it's using all those intrinsic muscles of the foot. So this is a really important exercise for these patients and probably most of the patients we're going to talk about today, because we need to strengthen those intrinsic muscles of the foot. Also, what you need to think about incorporating in your rehab for these patients, in addition to your typical strengthening with your manual work, they have not been utilizing that foot appropriately. So they're going to have a lot of tightening down and need a lot of manual work in all the joints of that entire foot. So you're looking at midfoot and forefoot mobilizations. You're looking particularly at that great toe. Am I at the 65 degrees of metatarsal phalangeal extension? So we're going to look at that manual work also for that patient. Gastrocnemius recession, this may be done in conjunction as another procedure for patients who have undergone a plantar fascia release, because if the gastroc is tight, when the limb goes to progress over for the gait cycle, if we can't get this excursion and translation of the tibia, I know I don't have the upper part of the leg right for this phase of gait. It's bugging me. I'm sure it's bugging some of you. I'm here in mid stance. When I start to go to that heel off and my tibia is translating, if I don't have that excursion of the gastroc, then when I go to my push off phase, that does affect that windlass mechanism. So a lot of times the surgeon may go in because he's already in there and do a gastrocnemius release. And again, this may be a procedure that you'll see concurrent for other patients that we're going to talk about today. Also, it's that lengthening to restore that length of that gastrocnemius. There are a couple of different ways this procedure is performed. One method is the Strayer method. This is going to be an incision in the top image here that is a little more distal. It's more at the musculotendinous junction. And what they do in the Strayer method is go in endoscopically, and they're going to just do some little splays here in this musculotendinous junction. The patient will be lengthened in a boot in some degree of dorsiflexion. And we need to make sure we incorporate stretching because the idea is that as it heals, it splays out and gives us that gastrocnemius length. The Bowman procedure is going to be a little bit of a higher incision, and that's going to come in more at this gastrocnemius muscle and do some little fraying of those fibers in order to try and get the length there through this little hook mechanism, similar to how you do the plantar fascia release, in order to try and gain some length of that muscle. When we're working with the patient post-operatively, if they have had this release done, they are going to be in a boot. And the key here, that patient must have a night splint also. That night splint is going to be important for at least the first 6 weeks to keep that foot dorsiflexed, because otherwise, if they're going down into that plantar flexion, they're going to get shortening of all that muscle that they just underwent the surgical procedure in order to release. You're going to make sure you strengthen that anterior tib up, because we need to make sure this patient now, in addition to addressing the stance phase for the plantar fascia, we need to address that swing phase mechanism, because they need to now make sure they clear those toes enough during that swing phase of the gait cycle. We'll do a lot of manual work to that scar. We want to make sure that as that muscle is healing, whether it's at the musculotendinous junction or higher up in the belly, that they're not getting fibrotic adhesions there, that we are getting a nice stretch on that muscle. Heel first contact with gait, neutral alignment during stance. Some things that you can look at as we're setting our goals for gait for these patients, looking at step length symmetry for the patient, because they probably have not been walking with that. It's probably been an antalgic gait for a long time. That's actually a good goal for all of our patients that we'll talk about today. Think about cadence. So we're looking at walking velocity, how quickly they can translate over a set period of time, maybe as a goal, but then also how many steps they're having in a set period of time and changing that cadence. If we want a longer step length, we actually want a slower cadence, less steps in each second. So those are some different goals that you can play with when you're looking at setting your goals. Think about it in terms of giving patients a little more of a visual feedback for gait, because we talk about proprioception, we give them manual cues, we're using all of our different sensors and biofeedbacks and things like that, which are fabulous. But we have so much technology now, maybe a video. Look at your gait, look at your walking here, see right there, that point, that's what we're trying to change. Let's physically try that now. Let's break it down. So, different ways that we can get a little creative for technology to help emphasize the quality of the gait cycle for these patients. And particularly, we're going to look at that translation in the later stages of stance, and then making sure we get the clearance in the mid phases of that swing and then at heel strike. Ankle fractures, there are many different presentations of ankle fractures, but I felt like couldn't have the course without at least mentioning them. So, the aspect that I'm going to focus on is looking at weight bearing. Our philosophy on weight bearing has evolved. We know that earlier weight bearing is and controlled early weight bearing is important in order to facilitate healing. Cardiorespiratory wise, it is very important. Circulatory wise, it is very important. We know mood wise for our patients, motivation, it plays a role. Many events, gastric motility, if they're up and moving more. So we know all those benefits are there. What we have now are several different philosophies on, well, how soon should we get a patient weight bearing? The terminology that seems to be most utilized, and we're talking foot and ankle right now, We're looking at late weight bearing would be their patient is remaining non-weight bearing for about 4 to 6 weeks. I come back from the days where everyone had a long leg plaster cast and we were in the hospital a week. But we are not doing that anymore. We are getting our patients up earlier. So earlier weight bearing would mean they're moving and actually putting weight through that extremity in a controlled manner within the first 3 weeks. And we're actually saying, because the advent of technology like the nitinol that we discuss, that within 24 hours, and we're doing immediate weight bearing for some patients, whether it's some type of partial or some of them are going right to that weight bearing is tolerated as we see more ambulatory procedures or these different types of release procedures. Most commonly, what we're seeing for early weight bearing is about the 2 week time period where the patient is able to start putting weight. You're obviously going to follow the protocol for the surgeon. And the reason that needs to happen is because there are so many different stabilizations that can be occurring and concurrent procedures that can be happening. Examining some of the research in terms of benefits and risks of moving towards this earlier weight bearing, looking at systematic reviews. These are from recent reviews looking at data from 2010 all the way up through 2020, where they have some longitudinal information on these patients, not talking about patients with pathological fractures, looking at mostly those ankle procedures. Patients who underwent early protected weight bearing, the first study, they looked at elderly patients. They wanted to go with patients over 80, but they could not find enough of a cohort from multiple studies. So they went with patients over 65 and considered them elderly, which it's hurting me a little right now as that's getting a lot closer. We're going to say upper middle aged people because it's all about activity, right? So when we look at these patients, they really found that there were no increase in complications with the earlier weight bearing for these different patients who underwent ORIFs. In looking at adults in these next two sets of studies between 35 and 57 years old, they did find the same complication rates. And consistently, the studies are finding that in the short term, within the first 2 to 4 weeks, obviously we're seeing less pain, more function in the patients that are allowed earlier weight bearing. But then as we get further out at 6 months, 12 months, things are evening out. But the benefit of that earlier weight bearing is that we know cardiorespiratory wise, it's just good for them in the long term in terms of even weight management and psychological, all of those benefits. Even though the complication rates aren't showing that there are less incidents of DVTs and things like that, we know generally that there are other benefits in overall function for these patients and that overall health benefit to early weight bearing. And the research is saying that without additional complications, I should say. Syndesmosis. Now we're going to look a little further up. So we're coming up to our syndesmosis. This is our articulation between our tibia and our fibula, above that talus for our ankle. We know that when we are weight bearing and doing different activities, as that talar head moves into that ankle mortise, and as we twist and move, we do have a little bit of a splaying that occurs. Injury to this can happen. We refer to it as a high ankle sprain, a syndesmosis injury, syndesmosis sprain, where there is a diastasis or a separation that will occur of these two structures, and then that's not stable. Unfortunately, this is a commonly missed injury when a patient has a lateral ankle sprain or significant fracture or other trauma in that foot and ankle, or even maybe higher up the chain and the ankle just wasn't the priority at the at the time because of other trauma management. So we might note this later down the road. So a lot of times these are delayed surgical procedures for these patients, which is why I want to highlight that, because it makes us think that they're not going to be ambulating normally on this entire foot during that time until they have their surgery. So we're going to need a lot of attentiveness to mobilizations and strengthening and proprioception in that, distal foot, not just where this surgery is going to be. Historically, what they've utilized are screws that are just going to come straight across, like in this left image, where they're going to rigidly stabilize this joint. The problem is, over time, then, as there's shock absorption, as there's different torsions that want to go through there, and it is not permitted, we are going to see breakage, loosening, and ultimately failure of that stabilization. So what they've come up with now, and sometimes they would, I should say oftentimes, the hope was that the ligament would heal and provide stabilization. So they would go back in and take that screw out. But in the interim, it does cause increased risk of arthritis in all the adjacent joints. What they move to now is a suture button to get something in there to stabilize that more naturally allows that little bit of movement that is going to occur between those bones, and not need that second surgery to go back in order to take the hardware out. So this is our patient who had a ligamentous injury. We're trying to stabilize that distal tibiofibular joint. And what they utilize now in many of the procedures is a suture button. So on the right here, we have parallel-ish to my line here. We have a polyethylene cord, and then we have these two little, they literally look like little buttons. And what's implanted into the patient, we see it here. The surgeon in the middle image is tying it off. And if you look really closely, kind of at that arrow, you can see the button there. On imaging, the button is here. So what they do is they will go in one side, they'll put the button in, exactly like how this cord is here. And then they'll come in, they'll put the polyethylene cord in and through, and then stabilize it on the opposite side. So this is going to be dynamic, and it's going to be stabilizing of that ligament as it's healing. It's going to provide that support for the joint. So it's dynamic though, so movement can still occur. So we can start getting that patient back to normal motion of that joint. Allows much earlier weight bearing because the cord is there then at the right length to stop it, kind of check the ligament. Some references describe it as kind of like a seatbelt there that is helping that ligament as it's healing, and it can stay in. And it doesn't inhibit in this second from the right image, this patient also has a fracture, so we can see the hardware there for that also. So it's not inhibiting those other surgical placements that are there. Don't have to worry about failure. And another added benefit is that this can be utilized for your patients with osteoporosis because there's nothing that has to grow into the area. The button is kind of like hanging on the outside and the cord is keeping it there. So it opens this stabilization procedure up for our patients with osteoporosis and earlier weight bearing. So we have those benefits. When we're rehabbing these patients, several considerations that we're going to have. Let's talk first about our patients who have the rigid fixation. So if you have a patient that did have that screw in place, they're going to be non-weight bearing post-operatively. Some surgeons automatically go in 4+ months out and take that hardware out. Others wait to see if there's failure or not and loosening of it from the different forces. But the concern is that patient is going to have adjacent joint arthritis developing. So it's important when you're rehabbing them to really make sure you're strengthening up the whole foot. Try to restore as much normal mechanics as you can, proprioceptively, strength wise. Really look at the translation over that foot to try and be proactive. Look at footwear, types of footwear, cushioning, how much external load are they carrying, activity modification to try and kind of like hold off that arthritis if possible. For patients who have the button that's implanted, that dynamic stabilization procedure, those patients are going to be weight bearing much earlier on, within 10 days. Though that patient will be up, will be weight bearing. We can start performing motions with those patients. We'll do our strengthening activities. For all of these patients, what we have to be careful of, regardless of which stabilization procedure they have, our concern is translation and compressive forces. So we need to be careful of, how with total hip patients, we make sure they're not, internally rotating, depending on the approach, to dislocate that hip. We need to make sure that these patients, particularly early on when they're healing, they are lifting and placing their foot, that they are not standing and twisting their body, because those translation and rotational forces are trying to splay apart this ligament that is trying to heal. So even though they have the stabilization, we need to bear in mind in our rehab and the forces that we're putting through that it's a ligament that's trying to heal. So we're going to be cautious with that. Watch if they're on slippery floors. Watch when they're going back to work, if there's vibration on the floor, that there's good padding and cushioning there, to bear that in mind during rehab. And when we're doing our balance and reaching activities, what directions we're having them go in and how soon. And even when you have them sitting and they start weight bearing, watch for those compressive rotational forces that may too soon stress that ligament that's trying to heal. Chronic ankle instability is the next condition that we will take a look at. This is going to develop in individuals who have had a history of lateral ankle sprain, and lateral ankle sprain can develop into chronic ankle instability. In some cases, it's just this feeling of giving way that the patient has, that they are unstable, that they can't trust that ankle. And it might be a matter of just more neuromuscular. They haven't had sufficient proprioceptive training to be able to recruit the muscles appropriately for balance. That's more of a functional chronic ankle instability. What the patients we're talking about today are those with a mechanical insufficiency. So because they have had that lateral ankle sprain of this lateral ligamentous complex, particularly of the anterior talofibular ligament and the calcaneofibular ligament, that those ligaments are remaining insufficient, or they've scarred down and haven't healed. They're not providing the stability to this ankle, and that individual is prone to be rolling that ankle and unstable. So we're going to look at the different types of surgical procedures that can be utilized to address that. The first one for chronic ankle instability, trying to repair those ligaments, is the rostrum anatomical repair. By anatomical repair, we mean that they are trying to replicate what that anterior talofibular and calcaneofibular ligament are meant to do. They're trying to maintain the footprints, the line of pull, and the normal mechanics. So, what they'll do is a direct repair. They call it a shirt over vest. What we're looking at here on the far right, the patient's foot is this way, so their toes are kind of over here, off to the left side to give you some orientation. And this is our malleolus. I'm dotting on the bottom here. So what they're going to do is a shirt over vest. They're going to pull down the different parts of the ligaments over each other, and they're going to suture them to each other to try and stabilize that. That's the rostrum. It's the gold standard here for either the anterior talofibular and or the calcaneofibular ligament. What they can do to add on to that, the modification, the gold modification, is where they're going to take that extensor retinaculum and kind of pull it up to have it give some extra support and reinforce those ligaments. So they're going to take the retinaculum and they will pull that up and over to support those ligaments to reinforce that repair. Another option is to utilize suture tape. So the suture tape, what we're seeing here is, let's go to this far bottom right image. So they will have the ligament that they repaired, and then they're going to anchor here into the talus and use its kind of like a cord or a tape that will then string across and come up to the fibula and be anchored in there. And we can see this tape in between these lines that I'm drawing on the top left and bottom right. It looks like cord or banding in there, and that'll reinforce that ligament while it is healing. If that's not sufficient for the patient, they may need to go to more of a reconstruction. And the next thought would be to again try and retain the normal alignment, the normal structure and functioning of that ligament when they reconstruct it. So they can reconstruct it using an allograft, a donor tendon, or if they are using an autograft, they're going to go to that semitendinosus or gracilis as that first choice to be pulling it out, or they will go down to the peroneus or the patellar tendon. So these are free tendon transfers. So they're going to take that and use it in a patient that has extreme laxity. It could have been, chronic ankle instability. You might also see this in patients who have just had a major significant acute rupture. If they have a patient who they know is going to be in high demand sports or functional activities, work demands, or someone who's obese where there's going to be a lot of external load on that ankle, they may opt for an anatomical repair with some type of grafting because it will solidify in a little bit little bit better. So what they're going to do is take that tendon and they're going to suture it down to replicate what those ligaments had done previously for that patient. So what they try and do is utilize these longer tendons so they can kind of come in and like zigzag it in here to reinforce that location. If that repair fails or is not an option for the patient, then they go to a non anatomic reconstruction. This is where they're going to utilize instead something in that local area. They're going to take a tendon from a muscle that is in the foot and ankle, and they're going to leave its origin attached and take its insertion off and move it to function as a ligament. So in these non-anatomic repairs, you're going to have a muscle that's going to function as a ligament instead. That's why they're calling it non-anatomic. There are several different names: Watson Jones, Evans, Snook. They all have different names. Evans first did this back in 1952, which is phenomenal to think that he came up with this back then. So what they're going to take for this patient is the peroneus brevis tendon. So they're going to take that peroneus brevis tendon that is here on that fifth metatarsal, and its origin is up here. They're going to snake it out. So now we have a free tendon. If we come down to the bottom image, what they're going to do is same thing they did with that free graft. They're going to zigzag that to make up for the calcaneofibular and talofibular ligament. They're going to zigzag it here and then attach it back up to itself on its origin. So it's no longer going to work as an everter of the foot. So if your patient had this procedure done, we know now that we need to have that patient work specifically on strengthening up of those everter muscles because they no longer have that peroneus brevis functioning for eversion. So they take donor sites from where there's a redundancy for the patient so that they're not leaving them short for functional training. It just means that in our rehab, we have to make sure that we're spending more time strengthening up the muscles that are remaining, get as much hypertrophy out of them as we can so that they can continue to function for that patient doing their primary action and during different types of activities. The challenge here with these non-anatomic reconstructions is that the muscle is still attached to its origin up here. So that means when that muscle contracts, it is going to pull a little bit. So while theoretically they've restored the architecture in that area of the foot, there might be a case where you get a little extra pull there, that it's tensioning on that site a little bit. And what they tend to see is some hindfoot malalignment that is occurring in those patients and a little bit of a redistribution of forces that could lead to some early arthritis that's occurring in those adjacent joints. At this point, though, it becomes when the surgeon's making their decision, if this patient has already had a failure of the anatomic repair, what are they going to go to? And they may make the decision that while they're risking that potential arthritis and malalignment, they haven't had to go yet to that arthrodesis for the patient where they know no motion is going to be permitted, or they're significantly restricting motion that will lead to adjacent arthritis. So this is kind of that in-between procedure to try and still avoid that arthrodesis. Now, surgical procedures have come so far with the different types of anatomic repairs and the different ligament reconstructions. We're seeing less of these non-anatomic repairs, but I want to make sure that I cover it so that if you do encounter that patient, you are aware of it. When we're rehabbing these patients who have the different lateral stabilization procedures, it's first important for us to know which procedure did they have done, a repair, a reconstruction, or not non-anatomical. And the protocols are going to vary based on what other concurrent procedures this patient may have had. That's why there's no one protocol. What we're going to look at is kind of a trend that has come up in the different research in terms of progression for these patients. Know that anytime a patient also has a tendon transfer done, maybe they also had, maybe it was a significant traumatic injury and they've had to have transfers done of other tendons also to try and restore motor function, everything's going to be pushed off further, because when we do have a tendon transfer where we are asking that muscle to work maybe in a different capacity, maybe it was a toe flexor, now we're asking it to be an everter of the ankle, we're pushing off our active movement by about 3 months. So we're not talking about those cases right now. We're talking about, generally speaking, with our repairs that we're going to see for our lateral ankle stabilization. They need to balance early mobilization and therapy to reduce the risk of that stiffness in the foot and ankle while allowing that repair to heal. Because we do have so many different joints in the foot and ankle, it is important to get that early mobility so that we don't have stiffness occurring in these joints, which most patients would then be prone to, or again, has developed at the point where conservative therapy hasn't been successful for them. So ultimately in rehab, we cannot forget looking down at all these other joints of the foot, all the way down to the phalanges, in terms of manual work, range of motion, and strengthening. That's true for everyone we're talking about today. Looking specifically at the ankle region where this particular stabilization procedures have occurred for the Brustrom, the Gold procedures, or if they've had a free transfer, their patient is likely going to be or will be immobilized initially. Post op day one, we're going to see them being immobilized. And then about 2 to 4 weeks out before they get into some type of removable arthrosis that is going to limit the eversion in that foot. And inversion. When we do start with active range of motion for the patient, we are going to be limiting our inversion because that's what's going to stress that particular repair location for the patient. We're looking at doing isometrics early on. That starts to get some proprioceptive feedback back, but it does not compromise or overstress that ligament that is trying to heal itself or has been replaced. Early on during those first weeks, we're working on proximal strengthening, cardiovascular status in a protected way where they're not weight bearing onto that foot. As we look at progressing the patient to more that 6 week time period, this is when we're starting with our subtalar range of motion. This is when we can start doing some of that inversion, eversion for the patient. We're again being cautious with inversion for them. We're looking at the wobble board, the BAPS board, heel raises, making sure that ankle is stabilized as we're doing it, starting in smaller ranges, maybe flat on the ground, and then later on progressing them to doing this off of a step. We're going to look at that eccentric control, may be more difficult for the patient early on. So they may be rising up as they gain their strength back, right? We start them bilaterally, and then they're going to take away the surgical side, lower themselves back down on the non surgical side. And then as we progress in that strength, they're coming up bilaterally, going down bilaterally before we get them to that single limb on that operative side, because we want to make sure that they have that control of that gastroc complex. They're not compromising the inversion, eversion stability and that repair as we're doing those heel raises and toe work. As I said, we're looking at mobilizations all the way down the foot. As we're in this 6 week time frame, we're going to be using the scale for loading activities. This is our patient that needs to learn to trust that foot and ankle again. So we're working on having them develop that proprioceptive ability, that ability to trust the foot and ankle, that it's going to be there for them, that they can control those muscles and timing. Maybe they need visual feedback also in order to accomplish that. When we look at more of our dynamic use for patients, there are some different studies trying to say, well, how do we know when the patient is really ready to progress? Historically we look at, well, so many weeks healing should have occurred, or oh, if they get to this muscle grade now they're ready. The current thing is looking at reactivity of the tissues in general throughout the body to decide when we're ready to progress patients, and that's what you're all doing. You're going to use that same thing with some of these post-operative patients within the protocol, for the surgeon, because we do need to think about tissue healing. So you're going to look at reactivity. How much swelling is there? How much discomfort is there after the activities? Some of the recommendations are that, well, until you can have a normalized gait pattern, you shouldn't really be working on dynamic weight bearing activities for that patient because it may stress this ankle too much. So we want to normalize gait before we add on more dynamic, challenging weight bearing with different surfaces and compliance surfaces and complexity of managing that patient. That we want to make sure that they can function without the brace before we challenge them on balance that is too complicated for that patient. Looking at some outcomes for lateral ankle stabilization procedures. I'll be honest, a lot of them, it was really difficult to tell what are the actual rehab protocols that they're utilizing. On the upside, the good thing is they all have positive outcomes. That in terms of looking at function for the patient, whether they had reconstruction with the gracilis or the modified rostrum Gould, where it was repaired and then reinforced with that retinaculum, when it was reconstructed, there was less sprain reoccurrence for the patients, but in all the cases, longitudinally, all of these individuals got back to full weight bearing, got back to all of their function and their work activities and what they considered normal life. Looking at the rostrum procedure of sewing it back together and adding the tape in there, they did find, whether they did early rehab, they were able to control the mobility for the patient and not disrupt that repair for the patient. 96% of the patients within 6 weeks went on to doing single limb hopping. I will preface this with the cohort for this study were soldiers who were ages, what were their ages? 19 to 51. So they were high functioning individuals previously, but that really shows the benefit of that procedure. Next, we're going to look at the peroneals in a different sense. We're going to look laterally if there is pathology of our peroneal tendons that are our primary everters of the foot coming down here. These individuals may present with pathology of the peroneals where there's an overstuffing of that lateral track for them, where they just don't fit in there. There could have been trauma to them and fibrosis with a lateral sprain. There could be an overuse type of injury that has developed, overstuffing of that tunnel. One of the conservative procedures that they do now is the tendoscopy, where they're going to go in. As we look at the tendon here, this is our peroneus brevis. Peroneus longus is nice and smooth. Peroneus brevis here is very frayed, where they can go in and they can debride that and clean it out for the patient. Remove any fibrotic tissue to create more space for that tendon to be able to glide for the individual. In the foot and ankle, we're starting to see more use of wallet procedures, and it really fits with this because the patient is wide awake. They are able to move that foot and ankle during the surgical procedure so the surgeon can see if they've cleared all of the fibrotic tissue, if they've created enough space in that pathway for those tendons to glide and move. And what they're finding is that these patients then can get up and have immediate participation in therapy because we're basically treating a tenosynovitis that has developed. Just debriding it and cleaning it out, allow that tendon to glide, and then we can get them on with strengthening proprioception and moving on to their functional activities. The next set of procedures that we will discuss are looking at peroneal tendon stabilization. So if you look at the image here, the patient is starting on the left. We're looking at their lateral ankle in this this region. Then we are resisting eversion, and I don't know if you can see it. I hope you can. Our peroneal tendon is all the way up over here now. So that peroneal tendon has subluxed out of the way, and that superior retinaculum is not holding it in place here, and it is popping out. Historically, what they've done is go in, ream it out, do a direct deepening to create the space. What they know now is that doesn't preserve that good, smooth cartilage. So the tendency now is they're going to come in, and if this is our bone on that lateral foot, they're going to ream out underneath it, and then they're going to hammer down the surface to keep that good hyaline cartilage and create a larger space for those tendons to pass. So it's that retromalleolar deepening, and then if they need to, they will go in and they'll repair that retinaculum. They will sew it back up in order to stabilize that tendon and give it space and preserve that good fibrocartilage for the patient. When we look at our peroneal tendon, in addition to it not being stabilized in some instances where we need to reinforce that retinaculum or deepen that space for it to relieve pressure, we can also have conditions that arise where the peroneal tendon needs to be repaired or reconstructed. Tearing of the peroneal tendon is often a longitudinal kind of fraying tear that occurs. And if that's repairable, oftentimes what the surgeon will do is go into that peroneal tendon that's torn longitudinally, and he is going to suture that up with some horizontal type of stitching. This is referred to as tubularization. It's utilized as kind of like a running stitch to hold that. It's usually utilized when there's less than a 50% tear. If it's deemed unrepairable, then an autograft might be utilized from the hamstrings. And then last option would be a tendon transfer from the flexor hallucis or the flexor digitorum. So we're going to look at each of these surgical procedures specifically. Looking at a repair, the surgeon will go in, they will debride out the tissue, they're going to evaluate the quality of it, and then a tenodesis is securing the tendon to itself. In some cases, they might adhere the peroneus longus and peroneus brevis to each other to kind of strengthen that insertion line of pull, because it semi closely retains the line of pull. Both will still produce that eversion for the foot. So it's just considered a repair if they kind of do a buddy up of those. Reconstruction is going to be utilized with an autograft of the semitendinosus or gracilis. This is going to be a free tendon graft that's going to be harvested and then moved over. And they are using, biologically, it's from the same patient, so it is greater benefit of healing. And then again, they're just going to place that tendon in its location, attach the ends of the tendon to each other, or if they need to, they'll attach the graft to the remaining tendon and then reimplant it into the footprint of the bone for the insertion. So those are going to be the reconstruction. The tendon transfer is where I want to spend a little bit more time explaining what the surgeon is going to do. Tendon transfer, again, we're taking a muscle that has a redundancy somewhere else in the local region and moving it over to now function as the muscle that is damaged. What they're commonly going to utilize is the flexor digitorum, or often the flexor hallucis. If you remember your Tom, Dick, and Harry from memorization on the medial aspect of the foot here, we have the tibialis posterior as our T, our flexor digitorum, our artery, our nerve, and then our flexor hallucis. And what they're going to do medially, they're going to take that flexor hallucis and they're going to thread it out. So we're in our right image here. And now imagine they're bringing it around. So we're in the left image here. They're bringing it around here. And then they're going to secure that tendon and have it become the peroneal tendon now. So it does change the line of pull slightly, but they are going to secure it in a way to try and closely resemble the peroneus muscle in order to try and create that eversion for the patient that didn't exist. Unfortunately, this is at the sacrifice of that flexor hallucis. That flexor hallucis that comes down under the foot here, it's not just for flexion of the great toe. Because of its line of pull here, it does contribute as a plantar flexor. So we are going to see some strength deficits in push off for that patient. So when you are rehabbing them, yes, you're going to focus on the eversion, strengthening, and retraining, but also be mindful that you may need to take a closer look at their ability to keep that flexor hallucis, that first ray, in contact with the ground during activities. Do balance with the shoe off to see that. And then look at push off during gait. We may have to do some extra strengthening of that gastrocsoleus complex to make up for that loss of the flexor hallucis for that patient. Interestingly, I forgot to mention this with the reconstruction. When they look at what tendons to utilize for our reconstruction of the tendons, they actually found that the semitendinosus, when they look in cadaver models, the cross-sectional area of it compared to the cross-sectional area of the peroneals, they find that the integrity of that tendon and the physiologic structure of it is very similar. And I like to mention that because when I read those studies, it makes me stop and say, wow, I think of the hamstring as such a big, bold, needs to be strong tendon muscle. Well, if our peroneals have similar characteristics in cadaver models, it's doing a really similar workload then just to control that foot and ankle. And it makes sense because it's controlling the whole body weight. And I always like that as a nice little reminder in the attentiveness that those muscles need of that foot and ankle to become functional for that patient. As we look at rehabbing our patient who has had the different procedures done to repair that peroneal muscle, if a tendon transfer was done, again, we are pushing off our tendon loading for 3 months. Another consideration is, in addition to, well, did they just repair it? Did they do a tendon transfer? Did they do a graft? Did they have to repair the retinaculum on top of that? Because the retinaculum is holding those tendons in place. So any pressure underneath tensioning those tendons can stress that repair of the retinaculum also. So if the retinaculum is not repaired, the patient is going to be immobilized, usually for about 4 weeks. Active range of motion will be able to start a little bit sooner at about the 2-week mark for that patient. Then, when you progress that patient, you're going to start with seated, do bilateral standing, and then progress them. If there is repair of that superior retinaculum, that patient is going to be non weight bearing and immobilized. And that immobilization will continue for about a month because that retinaculum needs to heal also, and they can't risk disrupting that. When tendon loading starts at about the 6 week time, we're going to be really cautious with that tendon loading. We are going to be careful and monitor that patient that we are not seeing that subluxation of the tendons. And when you start doing your scar work, which is necessary, you really need to know what structures you're on because you don't want to be frictioning and disrupting that actual repair of the retinaculum versus just some fibrosis or an adjacent foot joint that you're trying to restore motion to. So we have to be really attentive to our anatomy when we are working on this. Also, bear in mind, anytime we're working with our patients where the peroneals have been involved, as we work into later rehab and that dynamic stabilization for the patient, we need to work in that plane. So, we're working on lateral step ups for the patient, lateral reaching in both directions, dynamic diagonal hopping activities. So, remember that we need to challenge them in all those different planes. And the way that you can accomplish this even earlier in rehab is using those external loads that I've mentioned several times. That when you're doing these different balance activities, just change where the external load is because we know that that is going to change the internal forces the patient has to develop for balance. So if you feel that you're getting a little stale in your creativity with your balance exercises, yes, it's direction you're reaching in, but add some different external loads and then change the lever arms on those loads, and it will be challenging that foot and ankle differently. Pes planus is the next condition we're going to take a look at. This is our flat foot deformity for the patient, that dropping of in the top image here of that medial longitudinal arch. And then when the patient in the bottom image goes to progress over that foot, we're seeing that there's greater deformation in the foot and they don't have that good rigid lever to push off of for propulsion during gait. This can develop for several different reasons. It could just be over time, a patient who has maybe they've even had a past calcaneal fracture and there's malalignment with that valgus of the calcaneus. So those dominoes are falling and we're losing the arch. One deformity that we do see in our older population is the progressive collapsing foot deformity. This culprit here is the posterior tibialis. Our posterior tibialis, and this is a nice consideration also, that when you do have a patient that you're working on really any balance for and you're looking down at the foot, which I'm a big proponent of, really don't forget that posterior tib because it plays a critical role in kind of keeping that navicular and that apex of the arch in place to then allow the windlass to kick in for a good translation of the foot. So check that posterior tibialis in our older patients. It tends to develop pathology, tends to fibrose, and can actually fray or even rupture in some patients, and then they'll lose their arch because of that. So how we try to manage this and try to realign this calcaneus so then the arch can go back up for that patient, a tenosynovectomy, gastroc recession, or just repair of the ligaments that should be holding everything in place. Those procedures might be utilized if it's more of a mild case for the individual. If it's a patient where that posterior tibialis tendon, so they have a flexible foot like we're looking at in the left image, because that posterior tibialis tendon is not functioning to control the arch, then they might just do a tendon transfer like we looked at for the peroneals, but do the posterior tib, do a tendon transfer for that. What they're trying to avoid is an arthrodesis having to fuse. So, oftentimes, an osteotomy to try and realign the bony architecture is what's utilized. So, that's the procedure we will discuss. So, the medial displacement calcaneal osteotomy. The reason the foot is out of alignment here is because our calcaneus is tipped out laterally. And as soon as we do that, we can see that our arch is going to drop down. So calcaneus goes out, arch drops down. We no longer have a good stable foot for that individual. So to redistribute these forces, we need to get the calcaneus back in place. And an osteotomy, or cutting and removing part of the bone with that Achilles insertion, is the surgical procedure that's used to correct that valgus, or kicking out of that distal segment of that hind foot. The goal is to shift the Achilles tendon molar medial to avoid the hind foot eversion. So we're looking at a left foot here. So looking at the left foot for this patient, what's happening is the calcaneus is kicked out here. So every time we have a vertical load coming down, it's pushing that arch further down. As our gastroc is pulling up, it's pulling up at this angle, further pulling out into eversion. This is what needs to be corrected for the individual. So what they're going to come in and do, we'll use blue, no, we use green, is come in, and for that patient, they're going to remove the posterior aspect, small fragment of the calcaneus where the Achilles tendon is inserted, and they're going to move it medially. So now when this gastroc pulls, we have a better line of pull, and it's going to help pull that arch up. So we can kind of see that in the radiograph image. And then if we look on the left here, this is pre-op and post-op for this patient. So we can see post-operatively, they have a much better arch that's occurring, and we see the screw here holding that in place. Also, what we see is this changes the forefoot. That as that arch falls down, when we look to the left, we see this space between the first and second metatarsal, and that's better aligned once that calcaneus has been realigned for that individual. So they're moving at about 7 to 15 millimeters. It's not huge, but it's just enough to shift that line of pull, to redistribute all those pressures. And if you do have a patient where they do have pathology of that posterior tibialis, it might be just enough to take the stress off of it, so then you can rehab that tendon. As we rehab the patient, we're going to consider, again, this is a muscle that has been moved, so it needs to reaffix into the bone. It needs to heal, so we don't want to disrupt that, and that's why this patient's going to be non-weight bearing postoperatively. They're going to be in some degree of plantar flexion because, again, we don't want to disrupt that healing. It could be up to 6 weeks that the patient is going to be non-weight bearing, especially this patient where they're not permitted to do any dorsiplantar flexion. They're not using that muscle pump. We need to make sure they're elevated to decrease that risk of the venothrombus embolism. They can start doing earlier on isometrics in the cast. That's not going to disrupt that repair, or boot, I should say. As we look at progressing the patient, when we look at, yes, getting range out of the gastrocnemius, yes, restoring all the ankle motions, we need to think further down the foot, working on those foot intrinsics, working on toe flexion, toe splaying, all our different towel rolls and lifting and moving objects. We're going to be, again, mindful of our scar work and mobilizations further down into the foot. If that patient did need a flexor digitorum to posterior tibialis tendon transfer done, then we're going to push that off further. We might need, on any of our patients that have a tendon transfer, we can utilize biofeedback in order to help them tune in to those muscles and how to contract them again. And we also want to think about this patient when we look at the amount of external loads. Maybe weight loss for all of our foot and ankle patients and general cardiovascular health might be part of our plan. And I always look for opportunities for outside referrals for our patients and other resources. Do they have food insecurity? Can they get what they need? Can they get what they need that is healthy, that fits with their other comorbidities? So there might be opportunities there, particularly when we're looking at the foot and ankle post-surgically, to, yes, encourage healing, but also decrease some of those external loads if it's a dietary concern also, or just an education concern. So some opportunities there if you're looking at expanding practice too. Achilles tendon rupture procedures. If we do have a patient where their Achilles tendon has sustained a traumatic injury and ruptured, or over time where there has been degeneration and pathology of that tendon, this tendon can potentially rupture. Often the images show, just a big cracking and tear and cut of those ligaments. We know, and I like to explain to patients, that the tendon is more like, that rope, that parts of it has frayed and they're not connected. In addition to that fraying, what happens is the calcific tendonitis, where it has become osseous in nature, and that tendon is no longer functional tendinous matrix, and now it is basically bony and not functioning. So when they look at grading and whether a repair or a reconstruction is needed, they are going to clean out and debride first. So up here in our image, on the top right, we're looking at the tendon of this patient coming in here. We can see where there is disruption of that tendon. And then once they go in and they clean that out for the patient, on the bottom image here, um, this line parallel to it and above, we see the nice white healthy tendon. This line and below, above, we see nice white healthy tendon. And in between here is the big gap that existed once they debrided it out. So if that gap is 3 centimeters or greater, then they're looking at needing some type of augmentation, in order to repair that tendon. So when they look at the different tendon repair procedures, if it is not as severe as the case that we just looked at, if there's just maybe less than a 50% tearing, just some partial tears, there's not a significant gap in that tendon, the surgeon can go in, and I'm in awe of this, they're going in percutaneously and just lacing up there. There are many different techniques that they can utilize with the suturing, minimally invasive. They can do kind of like zigzags with X's. Some surgeons do vertical running stitches and then horizontal. Others do a bunch of X's. There are many different techniques that can be utilized. The goal is the surgeon is trying to use as few sutures as possible to obtain the greatest amount of security of that ligament. The key here is they need gap resistance, because that gastroc is going to function to propel the entire body weight plus external loads, and it has ground reaction force coming up at it. So gap resistance, that tendon not wanting to separate out, is important. So they need enough sutures to hold it in there, but they're trying to use as few as possible because they don't want extra scar tissue healing, because that would inhibit the ultimate functioning. The other consideration is pull-out resistance, that when they look at anchoring back down to that bony footprint, they don't want that to pull out from its location either. So it's a balancing that the surgeon is using there. Sometimes a reconstruction is necessary in order to regain some functioning back of that gastrocnemius tendon. What they can utilize is a tendon transfer procedure, and the flexor hallucis longus is often what is utilized for the tendon transfer procedure. So they're going to take that flexor hallucis longus. I'll do it in the upper image here. So they're going to disconnect that from its insertion down here and then snake it back up. And we can see the free tendon. Well, it's not a free tendon, I apologize. We can see the tendinous portion of that muscle, and the muscle belly is still connected up here proximally. So in a reconstruction, they're going to suture back together the existing gastroc tendon, and then they're reinforcing it with another adjacent muscles tendon. So we can see in the bottom image here that in the center we have the gastroc, and then next to it here we can see that they kind of in tandem with it. They're suturing in and then down to that bony footprint on the calcaneus, that other tendon to reinforce. Push off strength again is something we need to be attentive to in rehab, and check that purchase, make sure they're keeping that ray down. If the peroneus brevis is utilized, patients seem to report more that they feel that the foot is weaker, but again, we will re-strengthen that back up with our specific exercises. They've done EMG studies looking at these different types of tendon transfers, and I have the picture of this little boy doing a functional activity, because what they're finding is when we do our exercises, the carryover to recruiting those muscles in the foot and ankle for functional activity with these different tendon transfers, it's not as automatic. So when there are weak foot intrinsic muscles, there's a less of an ability to utilize that entire foot for functional activities like he's balancing on his tiptoes to reach for something. And think about it, even our elderly patients doing that, they're going to be reaching for something. It may not be as pronounced, but they're going to be doing these different activities. So the recommendations are to do those exercises that really isolate the foot intrinsics, to do toe spreading exercises, trying to keep the foot down and spread the toes, to do the doming types of exercises, because they're not habitual movements, and utilizing the foot, as I thank someone for asking about, how do you actually do those doming exercises? It does take some thinking and training in order for that piece that's so critical to balance to kick in ultimately functionally. So we need to reincorporate that, particularly in our patients that have tendon transfers. Tendon reconstruction with an autograft. This is an example of a calcific tendon that was removed. Up in the top image here, we can see the imaging just to the left of the line I drew here of all the calcifications. And then in the bottom here, we actually see that was removed and the gap that was created. This is significant. The size of these pieces, the largest piece was 9.3 centimeters long of the calcification, and the others were, 3 to 5 centimeters each. That is significant. That's basically the whole tendon. So there was a significant gap that was utilized. So the reconstruction that is done is going to take a free ligament transfer, and the surgeon is going to replace that entire ligament. So that's what we see to the right of the line that I have here. They'll attach it to musculotendinous junction and then back down to the bony footprint. As we're working with our patients following these different procedures for the ruptures, we can picture the exercises that we need to do. We need to make sure that healing occurs. Now that we understand the scope of the different surgical procedures and options, I want to rewind back to our patient earlier on that we're seeing in rehab when we're trying to conservatively manage that gastroc tendinopathy. That tendinopathy can present either at the mid portion of that tendon, so up a little higher at that mid portion of the tendon, or it can happen down here at that insertion of the tendon on the calcaneus. When it's up here at that mid portion of the tendon and it has not ruptured, if that once they debride it out, there's greater than 50% of the tendon thickness still present, then they may not need a graft. If they do have less than that, then they would need a graft. If it's insertional down at the bottom here, that Helgen's bump that forms is going to be resected out. They need to move the osteophytes that have also performed. And then again, they're going to utilize 50%. If looking at that bony footprint, if 50% of it is gone, then the surgeon is looking at doing some calcaneal reinforcement there to secure that back in place. And depending on how far back those fibers have recessed, they may need some type of grafting also. That particular patient, when it's insertional, they often will also have that gastrocnemius release procedure that we've talked about previously. As we look at the patient, rehabbing from these different complexities of trying to restore the function and architecture of the gastrocnemius, we're going to monitor this patient for potential rupture and loss of continuity of that new tendon or existing tendon that has been repaired. So your Thompson's test is going to be utilized. That's where you're going to, I'm pretending this is my foot, you're going to have your patient prone. You're going, actually, it's better this way. You're going to have your patient prone, and then you're going to squeeze that gastroc belly, and we should be able to see that they move into that plantar flexion. That lets us know that this tendon is still continuous and has not ruptured. No real consensus on specific protocols for how to rehab the patient. Again, there's that paradigm shift more towards that early mobilization, that early controlled loading of the tendon, with that resistance facilitating its healing, balancing that with avoiding rupture. Initially, when the patient is immobilized, they'll be non weight bearing in plantar flexion, so it's not stressing that repair. And then they're going to slowly move them along the way in order to increase that weight bearing. By about 8 weeks out, you might be starting to see them wearing a shoe with some type of gel heel cushion that'll create that space so they're still in some degree of plantar flexion. We want to make sure they're not wearing those big heavy shoes. We do want to look at the type of shoe that the patient is wearing. As we look at the different exercises that the patient is performing, we're going to avoid that dorsiflexion past neutral early on because that would stress that repair. And again, when we do start our heel raises, we're going to be bilateral concentric, take away the operative side, come back down, and then go back up. So we're going to start with the concentric and wait on that eccentric control and eccentric strengthening for that specific patient. Looking at some of the different outcomes of the different surgeries that have been done for the Achilles, looking at the insertional tendinopathy where they just debride it and anchor it down. There seem to be low overall complications. Patients have good return to their function. These are patients who did not have any rupture. They just need to adhere it back down. They do find that about 96% of patients are getting back to their sport and their activity. Exercises typically are including your heel raise, different sequences. You're looking at, as you monitor patients, when they do have surgical procedure that involves that gastroc, a good objective measure to look at hypertrophy of that muscle is a circumference measurement to see if we're making progress in not only gaining functional strength but also getting some hypertrophy of that muscle back. Looking at our hop testing, symmetry between right and left sides for those patients, and again looking at using heel wedges and maybe some type of boot earlier on as the shoe that does not allow that freedom of movement, something that comes up over the ankle more in order to control that amount of plantar flexion that would be happening during that push off phase of the gait cycle. If they go straight down to that sneaker or that sandal, that's a lot of movement that that patient has to control. So earlier on, start with something not too heavy, but more supportive for them to control that ankle. Anterior ankle impingement is our next procedure that we will discuss. Anterior ankle impingement occurs in patients who have had some type of trauma, typically to their ankle. Oftentimes, it's someone who had an ankle sprain or they have chronic ankle instability. Possibly, they had significant fractures in that ankle that have been stabilized, or maybe a smaller fracture that was more conservatively managed. Anterior ankle impingement happens in that anterior portion of the ankle joint, and what occurs over time in that patient from the abnormal mechanics or inflammation and swelling that has occurred in that area. They start to get fibrosis of the soft tissues in the area. So it might start out as that joint capsule that has become a little fibrotic, and now it's kind of folded over and it's tucking itself in as that patient is trying to do their plantar flexion and dorsiflexion, particularly plantar flexion. It would catch that anterior when they're in that deep plantar flexion. From the frictioning over, they might develop a little osteophyte. So what we're seeing here in this circle at the tip there is an osteophyte. In the far right image, we're seeing these frayed edges of that joint capsule or adjacent tendons in that area. And all of those tissues become entrapped when the patient tries to do their deep dorsiflexion, creates pain. And as this condition persists, that anterior fat pad actually starts to hypertrophy, and then that becomes encroached in this area also. So what this patient needs is a debridement in order to clean out all the soft tissue and even the osteophytes from that area so that they can have free movement occurring in that ankle joint. So they usually perform this as an arthroscopy to get rid of that fibrotic tissue as well as those osteophytes with that debridement. Since they're not moving anything, they're not securing anything, they're not transferring any soft tissues, this patient is immediately going to be up and weight bearing. We're stretching, we're strengthening, we're doing proprioception to get them moving immediately because they have not been. This is also your patient because they haven't been going into certain ranges. They are going to have tightness of that gastrocsoleus complex. They're going to have tissue tightness around their joint capsule and adjacent capsules. They're probably lacking that great toe extension. So we need to go all the way down to that foot. So we're going to look at a lot of manual work in addition to all of our strengthening exercises for this patient. Also know that these patients may present with nerve pathology because of the mechanism of injury of whatever their initial trauma was, or because of the different fibrosis that has been happening. We want to check that peroneal nerve integrity in terms of sensory as well as motor control for these patients. So make sure you're checking sensation, particularly of the dorsum of the foot, because once everything's cleaned out, that may have been pulling on the nerve, and now we need to restore the glide in there also. Osteochondral lesions of the talus. We're looking now at a bony deformity or bony trauma that has occurred. This one's better. So if we look at the surface of our talus here, this is what's articulating with our tibia at our talocrural or our ankle joint. This injury often occurs related to a significant trauma to the foot and ankle, and this can be significantly debilitating if it's not addressed for the patient. What happens is the cartilage here on the talar dome becomes damaged, and then if it does not heal appropriately, it can sclerose and actually damage the underlying chondral bone and that talus itself. So, what we're seeing on the imaging here on the right is a small defect in the talus. And here it is from another view. But on the left, from the scope, we can actually see what's going on inside that joint and that disruption of that bone. So you can imagine every time this patient puts any weight through the bone, even though it's a tiny defect, because of where it's located and the entire body weight goes through there, and then it frictions every time you move your ankle in any direction. This is extremely painful and debilitating for patients, and it really doesn't get a chance to heal. So there are ways we can try to manage it conservatively with offloading and different things. If that doesn't work and that subchondral bone is really damaged and breaking down from the repetitive micro trauma, then that patient is going to need surgery in order to repair this and try to get it to heal. And that's the first hope. The first hope is to try and encourage this to heal itself. So, bone marrow stimulation is the technique that's utilized to try and have revascularization occur of that talus. That's usually utilized for a small lesion. What they're going to do in the bottom left image here is go in and make these kind of little burr holes in the adjacent part of the healthy bone, and hopefully that'll encourage it to heal. Downside is it heals with fibrocartilage, not smooth hyaline cartilage, so it's not as resilient. That's why that's only utilized if it's a small defect. If it's a larger defect, then they're looking at grafts. So they will take out a couple of little donor cells, go grow those in the lab, and then we see here, so they may take them out of the knee, they're kind of like little plugs, grow them in the lab, and then they will place those into the dome here to encourage healing. The benefit of this is when they place those little plugs into the larger defect, because you're taking out the plug of bone with the surface on it that's still the hyaline cartilage, when you implant that and it heals, now it's healing with good hyaline cartilage. So you have a more resilient tissue. This is called the Oates procedure, where they do the osteochondral autograft transfer. So oftentimes they're pulling those plugs out, like we looked at in the previous image, from the non-articular part of the femoral condyle in the knee. So you need to monitor that donor site. And then if we look here above my arrow, you can kind of see they have big and small plugs that they place in as like a little matrix to stack and fill the defect to get that to heal. So what's really, really important with these patients is offloading. We can't have any compressive forces going through this talus because it's not going to heal for that individual. So when we look at that healing, that the phases of healing, that patient is going to be non-weight bearing initially. I am so sorry. I'm in Florida. Clearly the sun now is peeking through my window. Let me move. Sorry about that. Wow. All right. So I was saying, so the healing process that occurs for the oats transfer. Post-op day 1, patient's going to be non-weight bearing in some type of splint because we don't want movement there that can disrupt that healing that occurs. About 2 weeks out, we're going to start with some progressive protected weight bearing for that patient. It's going to be 6 to 8 weeks before this patient can be full weight bearing. Again, we don't want to do closed chain exercises early. This means even when you're training them for their ADLs and their different activities, that foot cannot be on the floor and they can't be accidentally leaning into it because it's going to compress that. We need healing to occur. This needs to be unweighted. No external loads. Even if they're sitting and they're resting something on their lap, that could be putting an external load through that foot if it's in a weight bearing posture. We want to really be careful. They're not actually going to put their foot down to balance when they're bathing or things like that. I'm going to be extra, extra attentive to that in these cases. When we do look at progression, we're going to hold off our single leg progressions until after that 8-week time period because we don't want too much force going through that bone yet. And then we're going to later get into sport specific training. Something to think about, we don't want too much translation going over that talar dome. So when you do start this patient with their weight bearing and their activities, you might start with sidestepping for balance for your weight bearing because that's not going to translate that tibia over this talar dome. You might start with retrograde walking, walking backwards before you progress to really going forward. So think about that direction of the forces. You don't want too much friction over that cartilage that's trying to heal. And again, these patients, we're going opposite of what I've been saying, where maybe use weight to challenge them. We really want to keep as much offloading as possible and then work towards adding the resistance and external load and forces on there. So even look at when you're doing your proximal strengthening for this patient, how are you having them do it? This is not the patient where early on you're getting them on the bike for range of motion because that would be compressive force going through there. Some additional considerations when we look at our pediatric patients for that growing bone. This condition can also develop idiopathically in some individuals, and that tends to be more in our pediatric cases, the osteochondritis dissecans, where the concern is what procedures should be utilized to avoid long-term potential risk of arthritis. Research hasn't really decided what is particularly best for these patients. The concern is if it's one fragment that is shifted off, they might be able to go in and just re-adhere it because that would preserve that good hyaline cartilage for those individuals. They are finding that maybe the drilling to stimulate healing is a little better for these patients. However, about 50% of the pediatric cases do still go on to have osteoarthritis develop in that foot and ankle. Another consideration is we need to look at ankle impingement syndrome potentially developing for these patients. So we're going to monitor all of our patients who have the Oates procedure or bone stimulation, anything done for the osteochondral lesion of the talus, monitor them that they're not getting osteophytes or inflammation in the capsule or fat pad hypertrophy that's encroaching then and creating an anterior impingement also. We want to avoid that. These are also our patients that we really want to look at weight management for them. That extra weight on there could hinder their healing. So that might be part of our additional referrals. Arthrodesis is the last category of procedures we'll look at. We'll look at arthrodesis and joint replacement. If everything else fails for the patient and they have a foot that they are unable to ambulate on, but they're trying to avoid amputation or they're trying to retain some degree of function for that individual, arthrodesis or fixation of that joint would be the procedure that the surgeon is looking at. These can be orthopedic patients or those with different neurological conditions also. So our patient with that pes planus that has maybe already had surgery, but now they're having significant osteoarthritis develop and that ankle's just not functional. They have an apropulsive gait. They just can't move their body through the gait cycle. They may be a candidate. Our patients with end stage, rheumatoid arthritis in a joint. Other patient populations are those with Charcot arthropathy, where we are seeing that significant deformation in the foot. It can't even fit in a shoe. They're really prone to that ulceration on the plantar surface of the foot that's placing them at risk for an infection and a potential amputation. Those are individuals who might be requiring an arthrodesis or a fusion of the ankle. The others are pretty obvious, but the one I want to highlight is a tarsal coalition. And this is something to think of when you have that patient where conservatively you're managing them and you have tried everything, you've addressed every diagnosis you think it is, and nothing is sticking. Imaging should be examined. Maybe they have a tarsal coalition. This means where the individual has, if we look at this calcaneus here, see how it has this extra little lip of bone coming out? This is a congenital deformity. It is fine in some people, but in some individuals, it does become pathologic. It's often seen between the calcaneus and the navicular bone, as in this case, or it can be seen between the talus and the calcaneus in the patient, and it can become pathologic, lead to osteoarthritis, and a fusion might be necessary down the road because of all the compensations the individual has had and the adjacent arthritis that has developed. The way arthrodesis is performed, it can be performed in many ways. It doesn't mean that every joint in the foot is no longer allowing any movement. Just to give an example of a couple of different arthrodesis, there is tibiotalar in the top left image where the tibia and the talus have been stabilized, so we're not having as much dorsal and plantar flexion occurring for that patient, but they will still have some inversion and eversion of that foot. And again, this is a last resort kind of procedure. Looking at the subtalar, where the talus is affixed to the calcaneus, that's going to be our patient where dorsal and plantar flexion can still occur because they do still have this joint intact, but we're going to see less movement here. So inversion, eversion may be more compromised for that individual. So all these patients will be substituting with more proximal balance strategies that we need to teach them, and triple arthrodesis is coming more down into that midfoot with that stabilization. When we consider patients who have had an arthrodesis, they are going to often use grafting. So we do need to know where that graft is coming from, if it is coming from a donor site, so we can monitor that for healing. Not smoking is extra critical for these patients. Managing their diabetes, weight management to ensure we have good healing. Often these patients have other concurrent comorbidities that need to be addressed. And there is no consensus on how soon weight bearing can occur, but oftentimes there's going to be radiologic examination with evidence of fusion before significant weight bearing is permitted, because there is a high risk of non-union that can occur. Depending on the research, they say up to 36% of the cases do result in non-union for our individuals. So you're going to be monitoring them for a functional decline. That might be one of your signs. Everything's progressing well. Suddenly they're having more pain, less function, less ability to utilize that ankle. That might be some of your indicators, in addition to monitoring if there's an infection, signs of infection, that there's failure happening. Patients are going to start out in protective non-weight bearing for about 6 to 8 weeks. Then, as the non-weight bearing joints or non-fused joints are permitted to move, we're going to see strengthening of our intrinsics going out our 8 to 10 weeks, really strengthening up what they do have left. In terms of how weight bearing is progressed, you're utilizing the scale for the individual. You may start, if the physician allows 25% weight bearing, and then you wait a week or two. And then, as long as they're having no increased pain, no signs of failure, then you're increasing maybe 10, 12% each 2 weeks after that, as long as it's tolerated well. In terms of our shoe and moving into full weight bearing, that full fusion is going to occur about 3 to 6 months out. Total ankle arthroplasty is an alternative for some patients that is evolving. This will limit that adjacent joint risk of osteoarthritis. It is for patients who have significant osteoarthritis in their ankle joint. In terms of management, it still does not restore full function of that ankle. Do not expect symmetry between both sides for the patient post-operatively. Strength, they do say, still remains somewhat limited for these patients. High impact activities in terms of work and sports is going to decrease the lifespan of these types of implants. We're going to monitor wound healing for this patient. Know that if they needed this arthroplasty, they may have also needed different types of tendon transfers. So we might be waiting that 3 months before we're doing anything active for the patient if they also had that tendon transfer. But generally speaking, by 6 to 10 weeks out, a patient without tendon transfer is wearing a typical shoe with some type of bracing to provide some stability. We can work on restoring mobilization to all of the adjacent joints. We're doing our resistance training for this patient, looking at the forefoot, the all movements of the ankle. In terms of our outcomes for arthrodesis versus arthroplasty, they are seeing significant improvements in both cases in the SF36 and the osteoarthritis scale. When we look at comparisons in those two, the osteoarthritis scale seems to be more sensitive to changes in individuals with these procedures versus the SF36. There is a little higher complication rate in patients who have arthrodesis because of the malunion or non-union risk. In terms of the larger systematic reviews, the research is really showing that our ankle arthroplasty has greater range of motion, significant improvements for those patients, but this particular group of studies found that they had a higher complication rate. So the research is still evolving on these cases. Aseptic loosening is what you're going to monitor for with the arthroplasty for that patient, which really would be similar to what you're monitoring for our arthrodesis patient, that progressing well, and then suddenly there's a decrease and an increased pain. I do want to finish up by looking at that lovely knee scooter that we see all of our patients using. And one of the concerns with that knee scooter is how safe it is, and do we actually need to treat it like an assistive device and treat patients with how to use it, teach them? And the answer is yes, we do, because there have actually been studies on it. And this one particular study looked at individuals from 18 years old to 81 that are using a knee scooter. And this is usually when there's that distal lower extremity pathology there. And they asked them, did you fall? Very simple question. And believe it or not, 25% admitted falling 1 to 5 times during their use. That's what they admitted. So I think we can assume it might be a little more than that. So we do need to teach patients what they're finding the most volatile time is hitting an obstacle, doing turns that are too sharp, just going too fast generally and not being able to stop, particularly downhill and on ramps. And what are they going to do? Take their foot off and put it down and compromise what's healing. An alternative that we're seeing developed is the knee crutch. I cannot find an image that isn't copyrighted, but basically it looks like an axillary crutch, except it has a pad here where the patient's knee would be flexed up and their foot would be bent out behind them. So with both of these, some of the concern is the compressive force at the knee and that popliteal fossa. Are we compromising circulation to that distal extremity that's trying to heal while the individual is utilizing these particular assistive devices? So some studies that have looked at them, what they're finding is that's not as big a concern as we thought. Less VO2 max compromise to the distal tissues with the hands-free crutch, with that knee crutch. So it doesn't have the axillary portion here. It just goes on their knee, and it almost reminds you of kind of like a prosthesis where the knee is bent behind them. So the individual's still using their leg to ambulate. They're finding that there's less compromise to the circulation in the distal lower extremity using that versus the knee scooter. They theorize because the individual's actively utilizing their proximal hip musculature for advancement and gait, that it's stimulating that circulation and not compromising. So obviously, if the patient's not even safe on the new scooter, is the knee crutch or hands-free crutch an option for them? You need to determine that, but I at least wanted to present that there have been studies that look at that circulation concern, and it seems to not be as much of a concern as we thought with that prolonged knee flexion. Lastly, I want to mention sural nerve neuropathy. This is a potential complication that can occur in patients from the different surgical procedures of the foot and ankle. So we do want to monitor this and assess sensation. We're looking specifically at monitoring the distal third of the leg, lateral foot, and fifth toe. So in this region, we are going to check our sensation for our patients that have the different procedures where that is the approach for them, because it could potentially be compromised. So we want to make sure we check that and differentially diagnose that from our compartment syndrome in particular, or is chronic regional pain syndrome potentially developing in this patient. The way we know there's a sural nerve neuropathy that has developed, if there is numbness, tingling, itching, those odd paresthesia sensations in this particular area. Oftentimes this is just transient and it'll resolve itself, but we do want to keep an eye out for it. That concludes the content portion of our course today. We looked at a lot of different surgeries of the foot and ankle region and highlighted what is done in the surgery that leads us to guide our clinical decision making during our rehab of our patients. With the nitinol hardware, are there concerns over nickel allergies? The orthopedic surgical implants that are utilized that contain the nickel titanium alloy, there is a possibility that they can cause a delayed type of hypersensitivity reaction. The metal from the nickel that is in the implant, it can potentially cause that allergic reaction in certain patients and then ultimately lead to other complications as a result of the surgical procedure. When they look at the use of the nitinol in not only orthopedics, but also dentistry, gynecology, cardiology, not so much in urology, according to the research, they are seeing some of these allergic hypersensitivity reactions. So it is something for us to consider in our patients following the foot and ankle procedures. What happens is all metals, when they come in contact with different biological systems, they do undergo certain changes. And what they find with the nickel in particular, that in certain people, cytotoxic T cells specifically, they release inflammatory agents that start to attack the nickel. Ultimately, what happens as that reaction is occurring, it's promoting the osteoclast activity, which is breaking down the bone where the stabilization is trying to occur. And it's also inhibiting the osteoblast activity, not allowing the new bone formation for the hardware to hold in place. So, as a combination of this, osteopenia starts to develop, osteolysis, that breaking down of the bone and loosening, and ultimately it can lead to failure of that implant. Now that this is becoming more known, this delayed hypersensitivity reaction is how they refer to it. Preoperatively, there's usually questioning about the patients to assess if they have had problems in the past with nickel or wearing costume jewelry or jewelry that's not made of pure gold. Do they have reactions to it? And then, if it's known ahead of time, alternatives can be utilized of titanium or carbon fiber type of implants during the fracture fixation or arthroplasty implantation. What we want to look for postoperatively in our patients, it's monitoring them in a similar way that you would for signs of other failure of the hardware that was implanted. It is a little bit challenging for the surgeon to diagnose because it's a diagnosis of exclusion. First, fixation infection need that deep infection needs to be ruled out, instability, implant wear, or if there's been a localized fracture. Most commonly, what is noted in patients that do have the metal hypersensitivity reactions is that there's a lot of local soft tissue reaction, delayed wound healing, or reoccurrent wound issues during the healing process. We'll typically see the other things that we monitor for signs of potential infection, localized pain, swelling, redness, that warmth. In addition, these patients may complain of itching and burning, in addition to those other symptoms that typically are mimicking an infection. In some patients, they've also noted that there are cutaneous signs of the hypersensitivity reaction where they may have an eczematous dermatitis that has occurred. In terms of workup for the patient, the physician is going to go through the battery to look at what if potentially if there's an infection there, and then another component of that might be dermatological testing to see if there is that nickel allergy, and if it is determined that's the case, then there needs to be removal and replacement of that hardware. What does WALLANT stand for? Wide awake local anesthesia, no tourniquet is what WALLANT stands for. It's an alternative to the use of general or regional anesthesia. It's utilized more frequently with upper extremity, but we're starting to see more use in the lower extremity distal foot and ankle procedures. When patients undergo general anesthesia, we know there are certain risks for those certain populations that have that general anesthesia. So, this wide awake procedure might be a nice alternative for some of those individuals. Um, what happens is the individual is fully awake during the procedure, that the surgeon is going to administer a mixture of a local anesthetic for pain control and then epinephrine. That'll provide the hemostasis, so they can view the surgical area, and there'll also be the anesthetic effect from what is administered. The key here is that the tourniquet's not needed because the medication is controlling the bleeding and allow good visualization of the surgical field. So, not needing the tourniquet, there's not as much of a need for as deep a sedation for the individual because of the pain from that tourniquet application. So it does lower those risks of side effects of anesthesia. So it can be utilized more in an ambulatory care clinic. The patient is coherent during the procedure throughout the whole time. The surgeon might be able to ask the patient to move that ankle. They're saying, particularly related to the foot and ankle, one of the benefits of this procedure is that because the patient is awake, they're able to move that foot and ankle during the procedure, see that it does function, know that they can trust it, that maybe there'll be some carryover of that post operatively in rehabilitation, that they know they can trust that foot and ankle, that movement was achieved, and the surgeon can check for tendon excursion, for stability of the fixation, look at what happens to the surgical site as the different mechanical forces are placed upon it from the active motion. So these are some of the different benefits that they are noticing. Also, they're finding that for many of the podiatric type of patients that have multiple comorbidities, there is that concern with general anesthesia of increased risk of complications. So the wallet procedure might be a good option, so they don't have to undergo that general anesthesia. For example, patients with our Charcot's disease, um, they often have end stage renal disease also, and they're on dialysis, or they have heart disease, which would make them a surgical risk otherwise. Also, if we think of our patients who maybe are undergoing different procedures for wound management, they have a lot of other comorbidities. So, for these high risk patients, it may be another option. Although for patients who do have peripheral vascular disease, wallet cannot be utilized because of the hemostasis that is utilized for them. There have been some studies that have looked at the benefit of this procedure for individuals who had hallux valgus surgery. When they looked at the patient's pain level 4 hours versus 24 hours postoperatively to those who underwent the wallet versus those who went through a traditional procedure, even with regional peripheral nerve blocks, they didn't really see a difference in pain. They did find that the mean length of stay was shorter. The time in the recovery room was shorter when the wallet procedure was utilized. So we know that there are benefits to that in terms of overall recovery. Something else that does need to be considered when the surgeon's determining whether or not to utilize this type of adjunct for the procedure is anxiety of the patient and whether or not they can handle actually being awake during the procedure and psychologically know what is going on during that procedure. So there's a little extra work up there to make sure that the individual will be able to tolerate the procedure. Is CRPS a complication after foot and ankle surgery? Uh, CRPS is a complex regional pain syndrome. Over the decades since this first became recognized in the 90s, it has undergone several different name changes. Some of you may know it as reflex sympathetic dystrophy, then moved to causalgia. Now it's recognized as CRPS. chronic regional pain syndrome. This is when the individual is presenting with a continued chronic pain that is disproportionate to the event that created that pain. So, to their surgical procedure in this case that we're talking about, where they're having that heightened pain level, the hyperalgesia, unprovoked pain, also allodynia. Now we have the Budapest criteria in order to grade and classify CRPS. So there are two different types. There's type 1 and type 2. Type 1 is looking at individuals where there is the presence of actual nerve injury, and type 2 is where there is not any obvious nerve injury. In either case, what we're monitoring the patients for post-operatively to know that this might be developing are not only the sensory symptoms of the hyperalgesia and the allodynia, we're also looking for vasomotor symptoms. So, where there is a difference in temperature between the limbs or an asymmetry in the level of warmth or coolness to the different extremities, as well as the color changes, the pallor or the redness or the complexion changes. In terms of pseudomotor responses, looking at the amount of edema and swelling, if there's asymmetry and how that's developing, we may expect some normal postoperative swelling, but if we're seeing that again, disproportionate. In terms of motor control, we're looking at trophic changes also. So there may be decreased range of motion. And then in terms of trophic changes, we may see changes in the hair growth in the area, the nail integrity in those toes, and different patterns of the skin. Those could all be indicators that CRPS is developing in addition to that high pain response. Looking at some different research studies that examined the prevalence of CRPS in patients with calcaneal fractures. They were managed non operatively. They did find that of a cohort of 340 patients in this one study, that 12% did develop CRPS. It seemed to be more associated with patients who underwent a prolonged period of immobility, female gender, as well as individuals who have a history of depression or panic attacks, substance abuse, and then also those individuals with diabetes mellitus and a history of smoking. They seem to be a little more of a trend to those individuals having a greater risk of developing CRPS. And then also, several studies noted that patients who early on to either their initial injury or to surgery had a greater pain level than anticipated for that injury or more challenges managing it. A greater percentage of those individuals did go on to develop CRPS. So, those are some things that we want to monitor and assess our patient for, looking at those sensory, vasomotor changes, as well as motor and trophic potential complications. That would give us a hint that CRPS may be developing because it is important to catch that early.